It is my pleasure to introduce my close friend and colleague, Dr. Daniel Yanni. Dr. Yanni is a board certified and fellowship trained minimally invasive thoracoscopic and complex spine surgeon. And I would tell you, on a personal note, if I or my family needed spine surgery, it is Dr. Yanni I would go and see, not just because of his surgical expertise, but perhaps equally, if not even more importantly, for his understanding of the entire patient's picture. Many times, patients or surgeons will look at an MRI and treat the MRI and say, okay, this is what we need to do. But his understanding of all the contributing factors and determining whether a patient truly needs surgery or whether they can benefit from other treatments, his knowledge in this space is unsurpassed. So thank you, Dr. Yanni, and welcome.
Thank you so much, Dr. Lewis. Appreciate that warm intro. I hope I deserve it. It's good to see you. I want to thank everybody at Hoag for this opportunity, for Dr. Lewis for putting this together, and for our entire production team that's worked tirelessly in the previous days and weeks getting this going. So with that being said, we'll take the next slide, please. A little bit about me. I'm a Southern California educated, Southern California grown, and I went to the East Coast for training in neurosurgery, and I did my fellowship in minimally invasive thoracoscopic and complex spine surgery. I am board certified and fellowship trained in spine neurosurgery. Next slide, please. So on to the topic of interest. As Dr. Lewis pointed out earlier, back pain is a huge factor why people seek medical care. It's estimated 10 million adults suffer from chronic back pain annually. It is the #1 cause of healthcare expenditures in the United States, with a direct cost of over $50 billion between the diagnosis, the treatment, and the rehabilitation. The majority of these patients have problems with degenerative and related conditions. These degenerative conditions can result in instability and compression of the spinal nerves, causing back pain and or radiating pain in the arms or legs. A few years ago, I did a radio show about health and wellness, and we talked about patients in their lives work so hard and sacrifice their health to amass wealth. And subsequently, in their later years, they sacrifice wealth to try to regain health. And this is the back pain paradigm is truly that example. Next slide, please. So before we go into non-structural, I'd like to get into some structural because it takes a real understanding of everything that's going on. And if you look at the lumbar anatomy, there are 5 bones in your low back that support the rest of your body in your upper back, your cervical spine, your thoracic spine, your head. And then below the lumbar spine is the sacral spine, the pelvis, and your legs. So this is a transition segment that's not very supported. All you have is musculature and ligaments. And in between the bones are discs, and at each level, there is a pair of nerve roots exiting. Now, here's the interesting part. There's a normal curvature of your low back that ranges between 30 to 80 degrees, and the apex of that curvature is somewhere in the mid-lumbar spine, around L3, L4. And it's important to understand this curvature because as we age and more wear and tear, that curvature is lost, and it changes the way that you're able to offload stress and strain. Next slide, please. On top of the supporting structure of the bones and the discs, we have the ligaments. And there's a variety of ligaments connecting each bone and disc to the next bone and next disc. So we have the anterior longitudinal ligament, which sits on top in the front of the spine. We have the posterior longitudinal ligament, which you can't really see in this slide, which runs on the back of the vertebral body. We have the ligamentum flavum, which connects the lamina posteriorly. The interspinous ligaments connecting the spinous process, which is what you're looking at in that bottom picture. The supraspinous ligament lying on top of the spinous processes, and the intertransverse ligament connecting the transverse processes in that top left picture. Next slide, please. You can just fly through that. Now, inside the spinal structure is what we're trying to protect, maintain, preserve, and is what's going to cause pain. And the spinal cord will end in the high lumbar spine around L1. And then we will have the cauda equina, which will be all the nerve roots below that. And 2 nerve roots will exit at each level. Next slide, please. So we've gone through structural anatomy. And we understand how structural anatomy can influence position and pain. But we want to talk about how do we deal with the back pain and back pain prevention. Body position. This is the most obvious factor that every one of us has had to deal with. How we lift, how we sit, how we sleep, how we stand. Everybody you know has felt uncomfortable in their low back at some point in their lives just in performing one of these activities. And this, try to explain, is the biomechanical reason behind the back pain. Exercise, aerobics, and stretching will help support back. Other considerations, including smoking, which can help hurt microcirculation, feeding the muscles of the low back and the disc and the bones. Weight gain and body mass index can also affect back pain as we're loading the spine before we do anything. Next slide, please. So what are non-surgical treatment options? There are many options that most people will undertake to deal with their back pain. Heat, again, improves the supply of oxygen and blood going to the back. Medications over the counter or prescription, such as muscle relaxants, narcotics, non-steroidal anti-inflammatory medications, or even acetaminophen. Exercise, that consistent stretching and strengthening exercises can help deal with back pain. Acupuncture, again, another comprehensive modality in addressing back pain. Chiropractic therapy, another comprehensive modality in addressing back pain. Next slide, please. Now, to understand why people have structural problems, we have to look at what we're doing. Most patients do not live their life laying down in an MRI machine. In 1999, Dr. Schmidt's group looked at 12 asymptomatic patients in neutral position, flexion position, and extension position. And they found a 16.4% decrease in cross-sectional area in extension, and up to a 44% decrease in interforaminal area in extension, depending on level. Cross-sectional area, meaning inside the spinal canal where all the nerve roots live. Interforaminal area, meaning the window that each nerve exits at that level of the spine. And they also found that the ligaments can change in thickness anywhere from 1.8 millimeters up to 4.3 millimeters between bending forward and bending backwards. Well, what does all this mean? Well, the whole idea here is that the spine is a dynamic structure, and it's designed to protect the neural elements, the nerve roots and the spinal canal and the spinal cord and the cauda equina is part of this biomechanical structure. And any motion can change that biomechanical structure. Next slide, please. So we've talked a little bit about anatomy, we've talked a little bit about prevention, a little bit about loads. Let's talk about back pain itself. So what is back pain? Patients come in complaining of back pain, and they may mean a variety of things. They could be talking about back spasms, they could be talking about bony back pain, they could be talking about sacroiliitis, they could be talking about a myriad of complaints. So what do we describe back pain as? We're talking about muscle spasms, cramping, and stiffness. There may be leg pain associated, tingling, numbness, or weakness. Pain and stiffness that gets worse over time and lasts longer than 3 to 6 months is concerning. This is a back pain problem. Periodically, I'll see patients who come in complaining of, oh, I had one episode of back pain a month ago and I've never had it again. And the question there is, well, what were you doing on that day or the day prior? And this is a patient who, we would do serial observation and not necessarily work up with more advanced imaging. But if this is a recurrent situation or a progressively worsening situation, imaging may be implied. Now, moving forward into the more urgent and emergent situations, such as bowel or bladder dysfunction, where patients can't control their urination, or saddle anesthesia, where you can't feel your perineal region, this is more of an emergency that should require an ER evaluation. In our senior population, we see a decreasing ability to ambulate distance. These are the patients that say, I can walk 2 blocks and I have to rest, and then I can walk another 2 blocks. That forward posture leaning over a shopping cart. This is all signs that there's an underlying narrowing around the nerve roots in the low back. Next slide, please. So frequently I get asked by my friends and colleagues, well, when do I get imaging? Again, any back pain and neurological manifestation radiculopathy, meaning irritation of the nerve root going down the leg or into the arms, myelopathy, which is signs when you have reflexes that are very brisk, limited range of motion, autonomic dysfunction, instability, or concerning history. These are all reasons to image. Most importantly, I go with physician suspicion. If you're concerned about obtaining imaging, if there's a question, let's get that question answered. So the next question I get asked is, what images should I obtain? Well, the easiest straightforward image to look at neural elements would be an MRI without contrast. But again, we don't live our lives laying down an MRI tube. So I always like to pair that with dynamic x-rays under gravity, so standing x-rays. And we look at the front view, the side view, bending forward and bending backwards. 36-inch standing images are great to assess where does the head lay over the hips. We were meant to have a horizon view. We were meant to be upright with a center of gravity. And any type of aberration of that, you'll have to have forces to combat that, which can bring out pain. If the patient has had previous hardware or previous surgery, we can consider a CT myelogram. Next slide, please. So now we get to the crux of this matter today of what are the non-structural factors that can cause, exacerbate, or feed back pain. And the first thing is going to be fitness level. The second will be weight gain, obesity, body mass index. And the third is going to be mental health. And we break down mental health and look at anxiety and depression, and they both have very similar effects on back pain, in addition to stress. Next slide, please. So let's start off with fitness level. Our muscles support and protect the bony structure of the spine. The spinal musculature can offload shear forces and strain that the spine may be exposed to. The stronger the muscles, the more the strain and force it can deal with. Think, if you will, if I ask you to lift a 50-pound barbell, are you going to be able to do that? And more importantly, how are you going to feel after that? Now I ask a bodybuilder or Dr. Lewis to lift that 50-pound barbell, and he picks it up like a feather because he has the muscles to be able to do that. Next slide, please. Weight gain, obesity. This is like a preload. So additional weight and load can exceed the normal displacement of the spine. So now the patient is coming into sitting down, standing up, or lifting with the spine already loaded because you have that extra mass. That excessive weight can accelerate wear, and you can develop muscle strain, disc degeneration, and facet arthropathy. Next slide, please. So I'd like to shift gears now from talking about fitness and loads on the spine to the psychosocial issues that can affect back pain and spine health. And Dr. Moore in 2010 published a paper about chronic low back pain and psychosocial issues. And in this paper, they estimated the prevalence of depression to be 2 to 3 times higher in patients with back pain than in the general population. So clearly, this is a major comorbidity. And the next question that would arise is the back pain happening because of the depression? Is the depression happening because of the back pain? Or is this a vicious cycle where they feed upon each other? And these are the key questions that we need to ask. And this is why, as Dr. Lewis was alluding to, we treat patients in a comprehensive manner where we are evaluating all the factors that can cause back pain. Next slide, please. So Dr. Strom's group in 2018 performed a meta-analysis, and they looked at 14 studies covering 4,800 patients. And the mean age of the patients in these studies was 49, so fairly young. And they extrapolated 75 findings into 5 categories of factors associated with anxiety and depression before and after undergoing spine surgery. Next slide, please. They found that the 5 factors that influenced anxiety and depression both before and after surgery were, number 1, pain. Pain causes anxiety. Anxiety can trigger pain. Similarly, depression. People are very saddened that they are in pain and they're concerned about their outcome and where they're going and how long is this going to last. Lack of information was a shocking finding in this paper. And this goes back to where are we educating the patients and how are we educating the patients? And that lack of information produced anxiety and depression because patients were uncertain where they were going and what was going on. Disability, again, disability is a big concerning factor. Patients have weakness or numbness or tingling, and the concern that exacerbates the anxiety and the depression, and again, feeds back to the disability, is where are we going? Are we going to get better? What are we doing? Return to work, it's natural that people want to get back to their lives. And the inability to get back to their lives can exacerbate anxiety and depression. And moreover, anxiety and depression can exacerbate the ability to return to work. And overall mental health. Next slide, please. They recommended development of educational aids to reduce anxiety and depression and improve surgical outcomes. And they identified 5 key points. 1, address the patient's understanding of pain and their ability to cope. 2, inform patients at a time and in a way and with informational content suited to the individual. Again, similarly, I'd like to kick back to our previous talk of informing patients suited to their problems. 3, address everyday activities, educating patients to be active according to their abilities, but more importantly, according to any restrictions that they may have due to having surgery. 4, educate patients in the direction of a new life trajectory. 5, addressing issues will decrease the risk of other and further psychological disturbances. Next slide, please. Dr. Marshall's group in 2017 published another paper. This was a cross-sectional study, and they looked at 218 people with chronic low back pain. And they performed multiple mediation analyses between pain and disability. And they tried to identify 4 factors to associate pain to worsening disability. And they looked at fear, catastrophizing, depression, anxiety, and then they did a separate analysis regarding physical activity as a moderator. And in the next slide, I want to show you this chart. Next slide, please. Actually, go back a slide. They did multiple assessments. They did an Oswestry Disability Index, which is a 50-point scale that we routinely assess patients with, that basically quantifies how does this patient's pain affect their life. They did the Visual Analog Pain Scale. That's the 10-point scale from the smiley face to the really not smiley face. They did a Fear Avoidance Beliefs Questionnaire, a Pain Catastrophizing Scale, and a Hospital Anxiety Depression Scale. And they correlated the scores between the different scales. Next slide, please. So this is the chart from this paper showing on the top, pain intensity with total effect to disability. And then they broke it down with pain intensity, looking at the fear factor to disability, pain intensity with catastrophizing to disability, pain intensity, depression component to disability, pain intensity, anxiety component to disability. And again, what you see here off to the side is physical activity was a separate modulator of certain factors, and I'll explain that in a moment. Next slide, please. So they concluded that the mediating effect of catastrophizing, but not fear or depression, was conditional upon participants reporting weekly performance of structured physical activity sessions. So in essence, patients who catastrophized wound up with disability, they had to perform some type of physical activity to get to that disability. However, the effect of fear and depression on pain-related disability was not related to regular physical activity. So this was completely independent, suggesting that psychological interventions are likely the best treatment of choice for patients who are suffering from these factors. Next slide, please. So then we look at psychology and back pain. And Dr. Ikamoto's group in 2018 published a paper reviewing psychosocial factors to look at the effects on back pain. And they looked at fear avoidance behavior, low mood withdrawal, expectation of passive treatment, and negative pain beliefs. And what are the effective options? And they identified that cognitive behavioral therapy restructuring the negative into the realistic was a good effective option. They identified mindfulness may help improve pain acceptance. And they also identified that self-management strategies for goals and pacing were effective for these individuals. Next slide, please. So in conclusion, non-structural back pain etiology vary widely. These can be fitness related, weight gain, obesity, body mass index related, psychology related, anxiety and depression. And it's critical that a multidisciplinary approach to back pain is taken to identify all the key exacerbating and attributing and triggering factors of the back pain. And through this multidisciplinary approach, we hope to have the best outcomes out there. Next slide, please. Little social media plug if anybody's interested. Next slide. And that's it. Thank you very much, Dr. Lewis.